So this is a test to see the possibility of recording, checking the sound quality for this lecture. We had a webinar this morning, but we ran into some technical difficulties. The internet was disconnected in the middle of the presentation, and also the sound quality was not very good. I have the computer about maybe a couple of feet away to my left, and I just wanted to check and see if the sound quality is going to be acceptable. So the first slide, we're talking about COVID-19 pandemic, and this is Islam Ibrahim. I'm an associate professor at University of California, San Diego, and I'm going to start with the first slide. This is the count as of 11:20 this morning of total cases worldwide and in the United States. In the United States, we surpassed 615,000. And the total death count is over 26,000, which gives the COVID-19 a fatality rate of about 5%. And this is about the same globally as well. Total cases now testing positive is a little over 2 million people, with total deaths of 128,000, a little over, which again carries a fatality rate of about 5%. There is multiple ads and resources on multimedia that talk about COVID-19, and we need to be careful what to read and what to believe. A lot of people will advertise things that are not true and give false hopes and therapies and medications that have not been tested enough and do not have any approval from any authoritative society to be utilized. So we need to be very careful and only read news from reputable sites and follow guidelines from reputable societies. I'm not going to tell you how the virus spreads because you already know. It is through the droplet mode of transmission, which means you keep your distance, and most likely you will not get the infection if you keep 2 meters or 6 feet away from a potential source of infection. Unless the person is coughing or sneezing, then obviously droplets can travel longer distances, sometimes even as far as 10 meters. So you need to be very careful. And if the person is sick or having symptoms of coughing and sneezing, it's much better to cough into your coat, elbow, whatever. And the best thing is just to keep a mask on to prevent your droplet from dispersing in the air and affecting other people. It is of paramount importance for healthcare workers to protect themselves. If you fail to protect yourself, you cannot protect your patients and your family members. We will talk about the best PPE, or personal protective equipment, in the questions and answer session, and how to preserve them. Obviously, with the high demand on PPEs in healthcare facilities, we are now running into trouble and deficiencies. So we have to become creative and figure out ways to protect our PPEs and conserve utilization, so we don't find ourselves in a difficult position when we don't have enough PPE to protect ourselves. And yet we still have to take care of patients with this terrible infection. One word on the pathogenesis of this COVID-19 viral infection. And the first step is, how does the virus gain access to the cells? So people are working on various models and receptors that allows the virus to gain access into the cells. And one of them is this receptor, the CD4-147, and the S portion protein of the virus, which is like a spike. It enables the virus to attach itself to the cell membrane. And then with the process of fusion with the cell membrane, it allows the injection of the RNA material intracellularly. So it is very logical to try to block the entry of the virus into the cells as step number one, the first line of defense, by finding an antagonist or a competitive antagonist that would bind that receptor and prevent the virus from entering through that gate. So a monoclonal antibody blocking this site, for example, like ipalizumab, would make sense, anti-CD147. You need to be careful with your healthcare facilities not to run into this third scenario at the bottom. This is a line that outlines demand versus availability of tools and supplies, staff, and all. And in the third scenario, when the demand is too high and in excess of your supplies, your system might be overwhelmed and could fail utterly. At UCSD, we came up with a plan, obviously needed a lot of modifications. This curve shows where we were at a capacity of 150 ventilators at any given time, and obviously things needed to be ramped up. It took a lot of planning, but we were able to ramp up our capability in the ICU to take care of 400 vented patients, and also to mobilize a lot of staff from the research labs, advanced providers, also residents and general practitioners, even from the community, who had some sort of interest or some experience in caring for ICU patients. So this extended team of quote-unquote ICU caregivers would work in the ICUs under the direct supervision of a board-certified intensivist. And that enabled intensivists to be spread a little wider and be able to take care of more patients. Now we are able to take care of 40 ICU patients per one intensivist with the help of all the medical professions I talked about. So staffing, we had to also rearrange our staffing availability, and this is something we can talk about in the question sessions. How to make a diagnosis. Obviously, we have the rapid test based on antibody detection of the virus, looking for the antigenic material. And that is very helpful, but PCR from a deep nasal pharyngeal swab remains the golden standard. Even though being the golden standard, it doesn't mean it's 100% sensitive. It's only about 70% sensitive. So if you have strong suspicion someone has coronavirus, classic symptoms, findings on chest x-ray or CT imaging, and they test negative, you still need to be vigilant and consider the patient positive and repeat the test. So one negative test has a 30% chance of being false negative. We need to be careful with that. You want to test for immune globulins in the serum. You need to understand that they take a while. I mean, IgG and IgM. IgM would rise in the serum to detectable levels within a few days, maybe 4 or 5 days, but IgG requires a full 2 weeks. This is important when we talk about treatment with convalescent serum for the level of neutralizing antibodies. But diagnostically, I don't think serum diagnostic antibody levels would be very helpful in the acute phase, and we would depend more on the PCR analysis of nasopharyngeal swabs. In the era of this pandemic, everybody who comes in with severe respiratory illness is considered COVID positive till proven otherwise. I understand the differential diagnosis of respiratory diseases and illnesses would include things like bacterial pneumonia, eosinophilic pneumonia, collagen vascular problems, congestive heart failure, aspiration pneumonias, and all that. But in this era, you need to be focused on COVID and consider everyone who has the classic symptoms and the findings radiographically to be COVID till proven otherwise. Symptoms, you already know that 90% of patients present with fever, some with cough, 25% with productive cough, 33% with dry cough. And shortness of breath is a very common presentation. More than 50% of patients who present with COVID have some sort of shortness of breath. Keep in mind that early on, chest radiography might not reflect any abnormalities. As a matter of fact, 20% of patients with symptoms might present with completely normal X-ray or even normal CAT scan. They progress very quickly, and the initial presentation radiographically is the ground glass appearances that could be rounded, peripheral, subpleural, and they tend to gravitate to the bottom of the lungs and the posterior lobes. And maybe that's why when we prone patients, we're getting the blood shifted away from the unhealthy areas of the lungs, and we're improving VQ matching that way. Classic findings on CT of the chest, as you can see, those peripheral ground glass opacities proceeding and progressing to full-blown consolidations in certain areas. But it is a patchy process, and it's a peripheral process, and it's progressive until the patient develops full-blown ARDS. The decision regarding when to request radiographic imaging and include them into your triaging decision is outlined here. And it basically common sense. If the patient has mild symptoms and he tests negative for COVID, there is absolutely no need for you to pursue radiographic diagnosis. If the patient has a positive test, and then you ask yourself, does the patient have high risk of developing advanced disease? And if that's the case, then you would image them. If the patient doesn't have risk factors and he's testing positive with some symptoms, but his symptoms are mild, and there is no high risk of advanced disease, then you don't really have to pursue radiographic diagnosis. It is, if the patient is having moderate symptoms, then you're obligated to do some sort of imaging if the patient is testing positive, or if the test is not available. And then you go from there. If the patient presents with severe respiratory illness, then if you have access to the PCR test and they test positive, then you are obligated to also do an imaging study. But if the test is not available and the patient presents with severe pneumonia, for example, then you can use your radiographic findings as a triaging tool to rule them in or out, and to consider them COVID positive or negative in the absence of having the test. You're very well aware of the risk stratification based on certain biochemical findings, including the dimers, ferritin levels, inflammatory markers, comorbidities. Now, what do you do for patients who present with COVID-19, pneumonia, and hypoxemia? We basically try to oxygenate the patients with various delivery devices. The one thing, or the one device that is not recommended is BiPAP, obviously, because it has a high chance of dispersing and aerosolizing the virus in the atmosphere around the patients. High flow is also questionable. We have a good chance of dispersing the virus with high flows above 30 liters per minute. The most recent recommendations say you can use high flow up to 30 or 40 liters as long as you cover the patient's mouth and nose with a surgical mask. It was found that covering the patient's face while they're on high flow oxygen with this type of mask will limit, or will at least prevent direct aerosolization of the virus into the immediate surrounding atmosphere. Nevertheless, you have to keep thinking all the time that you don't want to aerosolize the virus any more than necessary. If the patient is not doing well, continues to be hypoxemic, we don't want the patients to be struggling for breath either, because as they initiate negative force to breathe, the transpulmonary pressure is tremendous, and this can lead to more alveolar injury. Some studies talk about inserting an esophageal balloon to measure the pleural pressures and transpulmonary pressures, but if the patient is not doing well, short of breath, struggling to breathe, I don't know how comfortable the patient is going to be with inserting an esophageal balloon. So this is more of a research tool than an actual helpful clinical tool. It's a different story when the patient is intubated. So the key thing is try not to disperse the virus into the environment. Do not use high flow aerosolizing techniques for delivering oxygen. And then the third thing is do not wait on the patient for too long, and don't let them struggle. And every time they take a forced deep breath, they are damaging their alveoli. So if they go beyond high flow or even 6 liters, we would advocate early intubation versus waiting. The next slide, what happens if the patient is intubated? What are the things they need to be careful with? If the patient is in the ICU and on the mechanical ventilator, then